Good morning. The committee will come to order. And I want to welcome the witness to our hearing today. And I do want to apologize for the late start, but we're going to get started here. But today, we will be discussing the care and benefits available to veterans living with spinal cord injuries and disorders. You know, we have not had a hearing on this issue during my time on this committee and the oversight in this area. It's been long overdue. Before we dive into it, though, there is something that I want to say, and I think it's important that I do. I'm very disappointed to see that the VA did not send a witness from the spinal cord injury and disorder or the SCID system. That's what this hearing's about. And for the VA, should have prioritized having someone here from that office that is tasked with helping the veterans and their availability to receive those benefits. And I think it's important that the people in this room, the veterans, as well as the taxpayers and the veterans who are watching this hearing, this is the third time this year where we have been declined by the VA to have the witnesses that we requested. And it doesn't matter whether we're Republican, it doesn't matter whether we're Democrat, it doesn't matter whether the ranking member was, when he was in the majority. It's really upsetting whenever the VA makes decisions to overrule our decision on who we want and accept your judgment over ours. It is the responsibility of this committee to make sure VA takes care of all veterans. It is our responsibility for doing that to give oversight. And we actually do understand who we need to talk to. It is the third time this year that VA has tried to make a decision over this committee on who we need to talk to. That's not fair to the veterans, and it's not fair to the taxpayers. What you need to understand is we are the Congress of the United States. You are an agency. Yes, agency controlled by the administration, but your budget is ours. Oversight is ours. And we have to do our job for the American people, whether it's a Republican setting here or a Democrat setting here. It is not the job of the VA to decide who's going to sit before us. It is our job to request and your job to deliver. I hope I'm really clear on what I just said. With that, VA has long been recognized for its unique ability to provide top-notch SCID care. VA has 25 SCID centers across the country, each specifically designed to meet the veterans' issues head on and meet those veterans with spinal cord injuries where it is convenient for them. And let me put in perspective what I mean. One of the centers is in Hines, Illinois, which is about 3 hours from the top of my district, which means it's 6 hours from the bottom of my district. That's a long time to drive for an appointment. And I want to ensure VA is meeting the veterans where they are with the health care they have earned. It's that simple. Now, we've heard stories from veterans about missing doctor's appointments due to late or inadequate transportation with no coordination from VA. Those missed appointments have contributed to about $4 billion cost to the department from what we can calculate. We have also heard concerns about staffing shortages that have prevented SCID centers from operating at full capacity, as well as issues with patient safety practices in the VA's facilities. Some of the VA's shortfalls in this area are addressed in H.R. 8371, the Elizabeth Dole Act, including home care, long-term care, and access to SCID systems of care. It is incredibly important that we pass this important legislation to ensure VA can meet the need of all veterans. I hope my colleagues on the other side of the aisle, and I'm sure they will put politics aside and support this life-saving bill. Today, we will also examine VA's failure to ensure all disability exams are conducted in properly equipped facilities. A recent VA Inspector General report showed that a large number of contract exam facilities did not comply with federal disability law. In this day and age, that's unacceptable. Let's be perfectly clear. This is not a mere suggestion for the department. It's what we expect. VA must ensure that the veterans they serve have access to accessible and safe exam facilities. Without that, veterans are being restricted from the benefits they've earned. We know that disability claims processing itself is difficult to navigate. Veterans should not also face physical barriers to getting an exam. Access to benefits, including VA's Specialty Adaptive Housing Grant Program, are also crucial. Yet we understand that the application and the wait times for this program can present challenges for veterans and their families that they need help. Veterans are required to receive 3 estimates before they can get approval. And it can be difficult to find builders to do the work, especially if you're in a rural area. The advantage of keeping disabled veterans in their homes not only saves money, but it also gives the veterans and their families peace of mind. Congress has recently invested in this program. VA must make the rubber meet the road so severely disabled veterans continue to have access to the benefits that they've earned. Now, I'm eager to hear from the VA today about how they plan to fix these years-long problems. We will also learn from the expert witnesses who will speak about what more we can do to improve access to care and services for catastrophic disabled veteran community. I also want to welcome the many members of the Paralyzed Veterans of America who are attending the hearing here today. Thank you all for making the trip to DC, and I appreciate that you are spending some time here with us this morning. Now I'd like to recognize Ranking Member Takano for his opening comments.
Well, thank you, Mr. Chairman. I'm pleased to be here today to examine how we are meeting the needs of veterans with spinal cord injuries and disorders sometimes referred to as SCID. It is estimated that around a quarter of those with spinal cord injuries and disorders are veterans. Many patients live with the effects of these injuries for decades. It is crucial that VA can provide resources and help meet the needs of veterans with spinal cord injuries and disorders at each stage in their lifetime of care. Now, this includes access to equipment to assist them with mobility, ensuring a high level of care coordination to provide appropriate care for both preventative and chronic health care needs, and access to long-term care in settings that make the most sense for the veteran and their loved ones. As you will hear from many of our witnesses today, VA is uniquely positioned among healthcare systems to provide this standard of care. Its hub and spoke model is intended to help ensure that veterans are connected to the same high standard of care regardless of where they live. But this doesn't happen by accident. VA's position as the best provider of care for veterans with spinal cord injuries relies on continual investments in VA's infrastructure, workforce, long-term care services and supports, and other benefits for veterans with spinal cord injuries and their caregivers. I share the concerns of some of our second panel witnesses about VA's ongoing strategic pause in hiring and the impact it is having on staffing and care for veterans with spinal cord injuries. The highly specialized training and staffing ratios necessary to provide appropriate care to veterans with spinal cord injuries means that it can be challenging to fully staff VA's SCID system of care. However, workforce shortages lead to beds going unfilled, decreased access to care, and worse outcomes for veterans with spinal cord injuries. We must remain vigilant and ensure that vacancies at SCID centers are continuously filled. Now, because of the advanced training required of healthcare providers that are caring for veterans with spinal cord injuries, special attention must be paid to bolstering the workforce pipeline. It is vital to ensure VA is training and retaining an appropriate workforce for this population. And I look forward to discussing ways VA is doing this. Now, improving VA's infrastructure has long been a priority of mine, but the importance of this goal cannot be overstated when it comes to serving veterans with spinal cord injuries. VA must focus on infrastructure projects that build more capacity for SCID beds and ensure additional access within the hub and spoke model. At the same time, many existing VA facilities are in need of repairs or retrofits to ensure that they meet evolving standards of care for SCID veterans. Now, meeting both these needs will take thoughtful investment and planning, both from Congress and VA. And I look forward to working with VA on these vital projects. Finally, veterans need to be able to receive care in the venue that best fits their lives and needs. And many veterans rely on home and community-based services for health care and support. And through the Veteran-Directed Care Program, veterans with spinal cord injuries have the ability to hire their own personal care aides and engage in decisions about their care that ensures that it fits their needs and their lives. Most importantly, it is crucial that veterans receive the care that they need in the community without being subject to statutory spending caps that could drive them to institutionalized settings of care. Now, my colleague, Congresswoman Julia Brownlee's bill, the Elizabeth Dole Home Care Act, H.R. 542, meets these needs. It passed the House in December, and I urge the Senate to do the right thing to move it forward. And I agree with Chairman Bost that that politics must be set aside. And the last I heard, his party is in the majority, and they could bring a bill to the floor at any time to address those needs. So I would ask that he bring such a bill to the floor without the sort of, with a bipartisan agreement, basically, on what it contains. And there's bipartisan agreement on H.R. 542. And I just want to thank all of our witnesses for being here today. And I look forward to hearing from each of you about how we can ensure the well-being of all veterans living with spinal cord injuries. And I thank the chairman again, and I yield back.
I thank the ranking member for his opening statement, and we will now turn to our witness. Testifying before us today, we have Dr. Erica Scavella, the Assistant Undersecretary for Health for Clinical Services, and she is accompanied by Mr. Jeffrey London, the Executive Director of Medical Disability Examinations Office. And also on the panel, we have Mr. Steve Barshi, and the Director of Claims and Medical Exam Benefits Inspection Division of the Office of Inspector General. Dr. Scavella, you are recognized for 5 minutes to give your opening testimony.
Good morning, Chairman Bost, Ranking Member Takano, and committee members. My name is Dr. Erica Scavella. I'm the Assistant Undersecretary for Health for Clinical Services, and in that role, I directly, through my Deputy Assistant Undersecretary, oversee the Spinal Cord Injuries and Disorders Executive Director. I'm accompanied by Mr. Jeffrey London, the Executive Director for the Medical Disability Examination Office with the Veterans Benefits Administration. Thank you for this invitation to testify before you today. Spinal cord injuries and disorders, or SCID, present unique challenges and complexities often requiring specialized care and support. At VA, we are dedicated to addressing the diverse needs of veterans with spinal cord injury and disorders, ensuring access to rehabilitative services, specialty benefits and services, and assistive technologies. VA's SCID system of care is a comprehensive network designed to deliver exceptional care. This system operates under a hub and spokes model, wherein 25 regional SCID centers serve as hubs, providing comprehensive care, while primary care services are rendered at VA medical centers, acting as spokes by the SCID patient-aligned care teams. Mental health services are seamlessly integrated into the care plan, ensuring a holistic approach. Mobility interventions and walking aids, including walkers and canes, manual and motorized wheelchairs, and exoskeletons are tailored to fit the individual needs of veterans, enhancing their independence and quality of life. The system also offers a range of long-term care options, including non-institutional and home-based care, as well as support through the Caregiver Support Program, ensuring a continuum of care for those in need. While serving as a Marine on his second tour in the Vietnam War, Mr. Ron Kovich suffered a spinal cord injury that left him paralyzed from the chest down. For the past 53 years, Mr. Kovich has received his primary and specialty care through VA. This past July, on his 78th birthday, Mr. Kovich penned an open letter sharing his thoughts on his VA experiences. In his letter, he stated, "I have been a patient in the Long Beach VA Spinal Cord Injury Hospital for the past week for a bladder infection. The care has been excellent. Aides, nurses, doctors have been terrific. Things have vastly improved over the years over here. Ever since I was a patient in 1971, I've had to come to this hospital many times over the years, and I've seen many changes. I can honestly say that the care here of our veterans is now second to none." VA strives to ensure every veteran's experience echoes that of Mr. Kovich. To accomplish this, we provide various initiatives and programs to improve the accessibility in medical facilities, including providing eligible veterans with reimbursement for self-arranged travel, special mode transportation, door-to-door appointments, and funding for the Highly Rural Transportation Grant Service for travel coordination in highly rural counties. VA often continuously upgrades its facilities, integrates assistive technologies, and deploys mobile units for accessibility, prioritizing women veterans' unique needs with specialized facilities for their privacy, comfort, and tailored care. Outside of the facility, VA provides disability compensation, independent living training, and housing benefits, including the Special Adaptive Housing Grant Program you mentioned, providing financial assistance for home modifications to address accessibility needs. Additionally, we oversee contract examinations to ensure facility safety, cleanliness, and accessibility, and we work to increase the examination of our care through telehealth and acceptable clinical evidence exams. The Veteran Readiness and Employment Program additionally assists disabled veterans in preparing for, obtaining, and maintaining suitable employment. Finally, one of our most successful and impactful programs, the VA Adaptive Sports Clinics, provides the ability to empower veterans with spinal cord injury and disorders and engages them in physical activities tailored to their unique needs and abilities. These programs, which I've witnessed myself, allow veterans the opportunity to participate in a variety of sports and recreational activities, promoting physical fitness, social interaction, and overall well-being, completing the continuum of care. Chairman Bost, Ranking Member Takano, this concludes my testimony. My colleague and I are ready to answer any questions you may have.
Thank you, Dr. Scavello. Mr. Rucci, you are recognized for 5 minutes to give the OIG's testimony.
Chairman Bost, Ranking Member Takano, and committee members, I appreciate the opportunity to discuss our review of VBA's oversight of the contract medical exam facilities used for veterans' disability claims. VBA has paid contractors billions of dollars since 2017 for these exams, which may be needed to decide claims. The exams are typically conducted at the medical examiner's place of business, and those facilities must be accessible, safe, and clean. The 4 exam vendors that VBA uses are required to inspect these facilities for compliance with ADA and OSHA standards. We focused on veterans' feedback and experiences regarding the accessibility, safety, and cleanliness of the contract exam facilities. While we are not ADA or OSHA compliance officials able to cite specific violations, we did identify deficiencies at 113 of the 135 facilities we visited. These deficiencies created needless burdens and safety concerns for veterans with mobility issues and those with spinal cord injuries and disorders. We found that the deficiencies went largely undetected by MDEO because that office did not provide sufficient oversight of the vendor's self-certification of ADA and OSHA compliance. In 2021, VA modified the vendor's contracts by removing the requirement for MDEO to conduct random as well as complaint-based site visits. Notably, in fiscal year 2022, MDEO did not conduct any site visits based on veterans' complaints. Our finding was bolstered by 4 determinations. First, MDEO lacked independent access to the current inventory of contract facilities. By depending on the vendors to provide this information, MDEO could have incomplete lists. In fact, 2 vendors could not provide a definitive number of exam locations. Our first recommendation asked MDEO to maintain a list of the contracted facilities. While this may be the contractor's proprietary information, VA routinely handles this critical information like this in other areas and can protect this information in the same manner. Second, MDEO allowed the vendors to give customer satisfaction surveys rating their own performance to veterans instead of using an independent survey vendor. This may have resulted in VBA lacking a full picture of veterans' experiences. Therefore, we recommended that veterans receive the comment cards directly from an impartial survey provider. Third, MDEO lacked formal guidance for staff conducting exam facility site visits. MDEO staff were not trained on the standards of review, and their checklists weren't specific enough. For example, MDEO staff did not know specific criteria, like the minimum space needed for a wheelchair to turn. Also, we found their site visits were based on general observation of the facilities. We made 3 recommendations: to develop formal site visit procedures, update checklists, and create standardized training for staff. Fourth, MDEO did not validate the vendor's self-certification of ADA and OSHA compliance. The vendor's self-certification process was not comprehensive or reliable, likely contributing to the deficiencies. Importantly, MDEO was not doing reviews based on veterans' complaints. We recommended that VBA conduct complaint-based inspections and enforce the requirement for vendors to inspect and recertify the accessibility, safety, and cleanliness of all facilities. Because of accessibility deficiencies, some veterans could not complete exams at those facilities. Additionally, some facilities had safety deficiencies, including locations with blocked exit routes or expired fire extinguishers. Other facilities lacked clean common areas or single-use medical supplies. ADA deficiencies at facilities may make them unable to accommodate veterans with mobility issues. Our report has numerous examples of facilities where wheelchair users could not enter the location, so an exam was not possible. Rescheduling exams after veterans have needlessly traveled to a facility takes time and could delay their claim. We recommended that VBA analyze all veterans' complaints and create action plans to remedy them. Our last recommendation asked VBA to work with its vendors to determine if a veteran requires accessibility arrangements before the exam. All recommendations are open, and we will monitor VBA's progress on implementing the corrective action plans to address the hardships and safety issues that veterans with mobility challenges have experienced during medical exams. Mr. Chairman and members of the committee, I am happy to answer any questions that you may have.
Hey, Mr. Ratchey. We're now going to go to questions, and I will yield myself 5 minutes for the first questions. Dr. Scavella, we've heard that VA transportation is often inconsistent and not accessible to SCID veterans, which result in missing medical appointments. Can you tell me how many missed appointments are the result of VA transportation issues?
So thank you for that question. Our goal is to make sure we're providing access to our veterans. So we do have a number of vehicles to be used by our veterans who may be trying to get to appointments. If a veteran who has spinal cord injury and disorders self-schedules their appointment, we will reimburse them. If they live in a highly rural program or area, we have a highly rural transportation program. We also operate a veterans transportation program through volunteers. And then we do have the beneficiary travel as well as the Veterans Transportation Program. I will need to ask for a number. I don't have a number of how many veterans may have missed an appointment.
Okay,
due to
that is something we need to know from the committee. Also, with that, if you can check your records and try to get a calculation, because we tried to get our calculation, I said in my opening statement, we believe it's $4 million that it's cost to miss those appointments. So the number of appointments and then how much it has actually cost, how much it has ran over. Mr. Bracci, can you please explain to me the problems with the auto booth that is pictured right here behind me?
Yes, sir. There are a couple of issues with that particular audio booth that we saw. The first is accessibility. There was not a ramp available where a veteran in a wheelchair could get up into the booth. The second issue is the actual size of the booth. It wasn't large enough to accommodate a veteran in a wheelchair. The minimum dimensions are 60 inches in diameter, and it did not meet that standard. And this is an important issue because we did identify instances where veterans had accidents, and they tripped and fell trying to get in and out of an audio booth like this, and ended up, we saw one case where a veteran fractured their hip and required surgery. So it's not just a matter of complying with standards, it has real impact on veteran safety.
You answered my second question, and that would have been, have there been injuries and even severe injuries occur because of things like this?
Yeah, based on the work we've done, there certainly have been. We identified, I think we have 3 examples in our report that showed issues where veterans have had accidents and have been harmed.
Thank you. Dr. Scabella, what is the average time it takes from when a veteran applies for special housing adaptation to when the contractors begin construction of that adaptation?
So thank you for that question. I'm going to turn that over to Mr. London, who is the executive for the Veterans Benefits Administration.
Thank you very much for the question. Of course, it's variable depending on the types of adaptations that a veteran needs to meet his or their needs. Also, the location of the particular residence that's being modified and availability of contractors. But generally speaking, it can take over 90 days in many cases to accomplish what you asked.
So then the follow-up question on that is, and I know you can't do anything about location, but what else can we do to speed up the process? Because every day is a bad day with not having access to this.
I understand the question, and I agree with your sentiment. Some of the things that we've done to expedite the process to assist the veteran, because one of the things that needs to happen is the veteran has to choose the contractor, but we don't leave the veteran by his or herself to make that decision. We have a list of contractors that have successfully completed projects in the area to help expedite the process, and they also have familiarity with the details of what's required for these special needs.
Thank you. Dr. Scabella, I'm concerned about the staffing level at SCID centers. Do you believe that VA medical facilities are properly staffed for all SCID beds?
Yeah, thank you for that question. Our goal is to make sure we're providing the care that our veterans need, and we do have strategic hiring, and spinal cord injury and disorders is one of the areas that we have specifically communicated. We expect those areas to be fully staffed. We currently have a 9% vacancy rate across the country, which is a decrease in past 5 years. If you look at our statistics between FY 2019 and FY 2024, we have over 232% growth in that particular area across the country to include all staff.
Okay. Well, that's, I guess, how you would respond to the VA facilities there's a lot of claims out there that you're short staff nurses in and around the country.
So there is a healthcare shortage generally, both within and outside of VA, which we are contending with. We're being creative in our salaries, making sure that we're being competitive, making sure that we provide the opportunity for growth once employed by VA, to make sure that our environment of working is something that's desirable by people so that they'll be willing to come into VA. And we're giving, making sure that our benefits packages for employees are enticing as well. So we are also collaborating with university affiliates to make sure that we bring in the top talent into our organization. We realize that people who train within VA, like myself, tend to come to VA to work permanently.
Yeah, so my time's expired by over a minute, but thank you very much and I will now recognize the ranking member for his questions.
Thank you, Mr. Chairman. Mr. Bracci, thank you for the recent OIG report on accessibility and safety at contract facilities for disability exams. Veterans may only use these facilities for a one-time exam, yet OIG found physical barriers that hindered access for veterans who use wheelchairs, among other things. Now, I'm concerned that there may be similar issues with private sector providers that veterans are referred to once they start using the VA healthcare system. Has OIG looked at VA's community care network providers and whether they're meeting ADA and OSHA standards?
To my knowledge, we have not looked at that issue.
Okay, well, thank you. Would you tell the Inspector General Missel that I would like him to look into this issue?
Yes, I see.
Thank you. Dr. Scavella, I understand that as of last month, only 153 of the 181 long-term care beds that VA is required to have in operation at its SCID centers are actually available for veterans. Can you explain why?
So thank you for that question, Congressman Takano. We have some challenges in some places doing staffing, and then there are a variety of reasons that may affect our ability to have a bed open. So if we do have a bed available, but it is occupied by a veteran who may have a certain infectious disease, we may have to not use the other beds in that room.
Okay, well, so I'm hearing staffing, though, is the kind of predominant reason. Lack of staff. These beds are empty because there's no one there to staff the veterans who might fill them. And just to be clear, veterans with SCID need access to long-term care beds at VA. Is there a waiting list?
We don't have patients who are waiting to get in. If we are unable to provide the care within our organization because of the acuity of this illness that they have, we will make sure that we coordinate with our community partners, recognizing or transfer to other facilities within our VA.
So you're saying there's no waiting list because you place them in community partners?
If we are unable to house them within one of our hubs or provide care in our spokes, it's
Okay.
a complicated answer.
Okay, and I could go into whether or not those community care facilities rise or meet the level that provide at VA, but I want to go down another train of thought here. I'm sure you understand that my concern that VA is proposing to move up to $10 billion from direct care and medical facility infrastructure to community care in fiscal year 2025 to cover an expected shortfall. Now, this certainly won't help fill the vacancies and staffing that we're talking about in VA's SCID system of care. How can VA make the needed investments in the SCID workforce to provide the best care for veterans if we are diverting so much funding to community care?
So as I've said earlier, our goal is to try to keep our veterans in our system. We want to make sure that we're providing the care for veterans. We have increased our staffing in spinal cord injuries and disorder by over 230% in the past 5 years, and we're making sure that we are enticing employees to come into our system as a provider of choice.
I get that, but the administration is making a decision to move money out of direct care, which you need the staffing. Beds are empty, and that's forcing you to put people into the community already. I share I share the concerns that PVA expresses in its testimony about VA's decision to severely limit hiring in fiscal years 2024 and 2025. VA issued a May 31st memo directing facilities to continue filling vacancies in VA's spinal cord injury system of care. But how is VA going to hold the field accountable and ensure that there is sufficient workforce to meet the needs of SCID veterans?
So thank you for that question. We are coming on the heels of a remarkable over 61,000 employees who've been brought into our system, mostly in direct care positions. And we have increased the staffing in our spinal cord injury disorders. We only have a 9% vacancy, which is lower than it's been. So we continue to prioritize that through our strategic hiring to make sure that we're providing that care.
Excuse me for interrupting, but have you set a target date for the field to address staffing challenges that led to the closure of long-term care beds specifically? Is there a target for that?
So the request is to make sure we are strategically hiring, realizing that it takes time to bring in nurses and physicians specifically because of the requirements to make sure that their credentials are what they state. So we have a directive or a memo from the Undersecretary for Health regarding how we should be moving forward. It's clear to our organizations, and the expectation is that those direct care appointments and opportunities would be provided first. So our plan is to get those employees
I'm glad it's
appointed.
prioritized, but has he set a target date?
I'd have to look back at the memo to give you that date.
Could you get back to me on that? And I hope if there isn't one, that there'll be a concrete target date set to fill these beds, to staff these beds. I yield back, Mr. Chairman.
Thank you, Ranking Member. Dr. Miller Meeks.
Thank you very much, Chairman Bost, and thank the witnesses for being here. It's a little bit surreal to me because I started out my career as a second lieutenant nurse in the Army stationed at Walter Reed on Ward 10, the neurosurgery floor, so taking care of traumatic brain injuries, which we didn't call them that at the time, spinal cord injuries. I've flipped my share of striker frames and also worked with halos. And my husband, interestingly enough, got out of the military to get his BSN. He was an E6 LPN when we met, and took care of a spinal cord injured veteran as a private LPN to do that before the VA provided that care. So I know how challenging this can be. Dr. Scavella, according to some of the data obtained by committee staff, we know that 18% of patients seen in the past 3 years for spinal cord injuries and disorders were also seen for substance use disorder or had that diagnosis. Do you believe that the VA has the capacity to provide inpatient mental health and substance use disorder care?
Yeah, so Dr. Miller Meeks, thank you for that question. We do feel as if we have that ability because we are an integrated healthcare system. Mental health is embedded in the patient-aligned care teams that provide primary care for this population of veterans. If they require substance use disorder on an inpatient setting, we are able to provide that care as well. We do have systems across the services across the system.
Are the SC, and this is again reminiscent of the old Walter Reed, are the SCID units using 4-patient bed models in their centers? And do you believe that having 4 patients in a room is appropriate for minimizing risk of infection and creating a healing environment?
Yeah, so Congresswoman Miller Meeks, thank you for that question. We have older facilities, as you just reminded us of, that do have 4 beds in some rooms. We are constructing facilities that do not have that configuration. So our goal is to try to reduce the size of the rooms to make sure that we're giving patients the privacy, both from a mental capacity and from a healthcare capacity. So that is not the standard at this point in construction. When and where possible, we will not use all 4 beds in a room to make sure that we are giving patients the privacy that they require.
Thank you. And just to follow up on Representative Takano's question, what are the main barriers, and you may have answered this, to staffing SCID centers as opposed to other VA medical facilities?
Yes, so thank you for that question. We understand that this is a highly skilled area, as you just mentioned during your experience. These veterans require lots of care, lots of patience, and so it takes a certain type of clinician or professional to be a provider of that care. So making sure that we recruit, retain the highest skilled employees in those areas is really important. We want to make sure that they have the highest quality, and so we review that on a regular basis through our ongoing professional practice evaluation. And we also want to make sure that once we bring them in, that we're giving them the tools to grow as professionals to make sure that they stay with us and continue to serve veterans.
I would say it was some of the most rewarding medical care as a nurse or a doctor that I'd ever administered. Mr. Blake, the committee is aware of a few promising technologies. I think we cannot have this hearing without mentioning the innovation that's occurring in this space, mainly brain-machine interfaces, which hold immense promise for catastrophically disabled veterans. What research or outreach has PVA done in this space and technology and its key players? Excuse me, second panel. Thank you very much. I yield back my time, but I'll submit the questions for the record.
Representative Brownlee.
Thank you. Dr. Scavella, you testified, I think in response to the chairman's question, that you don't know how many missed appointments there are due to transportation. But why would you ever turn down a catastrophically disabled veteran who had travel issues once they got to the VA? Why would you ever turn them down for his or her appointment?
So thank you for that question. I'm not aware of us turning anybody away, and that's why I don't think I can answer that question. We would make sure that we're providing that care, whether they're late by a day or by a minute. So it is important that we are providing the care when and where they need it. If we are, for whatever reason, whatever the condition is of that veteran, if they're too ill for the capabilities of the facility that they show up in, we will make sure that we get them to the appropriate level of care, whether it's in the VA system or in the community. Obviously, our goal is to try to keep them within our system because of all the things I've talked about with continuity, making sure that we can provide that care, not just for whatever the issue is, but the whole health of the veteran.
So what are your, how would you describe your best practices for the LGBTQ plus community for women who are catastrophically disabled?
So thank you for that question. We appreciate legislation that has helped us to ensure that women veterans who have spinal cord injury and disorders can receive the care in-house or at home that they require, as well as for things such as mammography, which is difficult related to positioning them. So we are very grateful for that. Our goal through the messaging from the secretary through to each employee is to make sure that we're providing care for every veteran who's served. Our mission statement has changed to reflect that. And both the secretary, the deputy secretary, who is very concerned about us making sure that we are here for women veterans who may not see their place, that we are providing that open and welcome care.
What about the LGBTQ?
LGBTQ, we have several different projects related to making sure that we're being open. Currently, June is Pride Month, so we are recognizing our population of both employees and veterans during this month to make sure that we're providing that care, that people know that they can see themselves as their authentic selves here at work. So there are a lot of things ongoing to make sure that we are being open and responsive to the population.
So my understanding is when women with spinal cord injuries or disorders show up at a health clinic or a medical center, that they are then required to go to an SCID center first in order to be referred to by an OBGYN. Is that true?
So we are going to try to provide the care to a veteran who may show up in whatever care place she may show up.
I understand that's your goal, but I want to know what the reality is happening today.
So when we have a new patient come in, if they're coming in for their care, if they are spinal cord injury and disorders veteran, we would want to make sure that we're tying them in with that population to provide that care. If they're coming in for women's health services and we can provide that care in the women's health clinic, we will do that.
So basically you're saying that's not really happening. If they show up at a medical center or health clinic, they're not getting referred to an SCID center?
Unless you have a specific instance that you'd like me to look into, I'm unaware of that.
Okay. Can you speak a little bit to the differences between the Elizabeth Dole 21st Century Healthcare and Benefits Improvement Act and the standalone bill that was supported in a bipartisan way, I will add, the Elizabeth Dole Home Care Act. Can you talk a little bit about the differences in what the VA really supports in terms of those two bills?
So thank you for that question, Congresswoman Brownlee. I will have to take that back. I don't have the department's technical review of those at my fingertips at this point, so I can't speak freely about that.
Great. Well, the last thing I will just say, too, is having had a meeting in my office yesterday, and that I know that there are PVA members in this room who have personally experienced being turned away after traveling to VA appointments. So I would really encourage you to speak with them and hear their stories, because I think what you're saying and what we're hearing from PVA members don't line up. And obviously, we need to get to the bottom of that. So I would appreciate it, and with that, I yield back.
Thank you, Representative Brownlee. Representative Luttrell, you're recognized.
Thank you, Mr. Chairman. Dr. Scavella, if I were you, I'd take a hard look at the room behind you before you get out of here and leave, because they were shaking their heads to Ms. Brownlee's point. So that's something you're going to want to have an answer to when you engage with the committee, okay? How long have you been in this position?
I've been in this position since January of 2022. I've been at the VA for 25 years.
25 years. Mr. Bracci, that IG report, are there any bullet points on that report that have been replicated over previous years?
Some common themes, as far as the contract exam program, we've been focusing on that for several years now because of the millions of veterans that impact.
What discrepancies that we're seeing in the VA system that are ongoing?
I would say that just the oversight by MDEO, we see that continuously. I will say that they address issues as we identify them and as we make recommendations, but it's the proactive oversight up front.
Well, the oversight report that you submitted and the previous oversight report that we've engaged with are stating the same thing over and over again. So, Dr. Scavelli, can you tell me why the VA system is, I guess in my opinion, I'm going to say taking this kind of haphazardly and not engaging with, when you have spinal cord injuries, again, I'm saying because I'm looking behind you and I'm seeing everybody, right? And so I really want to know why this, the Secretary's number one priority is suicide, and I appreciate that wholeheartedly, but when our veterans have lost the ability to be mobile, amongst other things, it runs neck and neck. And if we continue to have an IG report that's pretty much beating the hell out of the VA, I want to know why the leadership's not taking advantage of the situation and fixing the problem. And so far, you haven't given us any dates. Now, I've listened to the committee members, including the ranking member, ask questions. What are the dates? The dates. And in the military, we ask for dates. Those are hard lines because we function that way. That's how we operate. So I want to know when the VA is going to throw us a hard time and say, hey, this is when we're going to fix this. Can you answer that question for me?
So thank you for that question, Congressman Luttrell. We are making sure that we're answering the mail when it comes to these findings. I'm in the Veterans Health Administration.
What does that mean?
I'm going to turn this question over to the Veterans Benefits Administration, who runs this program. I do not oversee it.
Mr. London.
Congressman Luttrell, thank you very much for the question. And to answer your question specifically, the recommendations that OIG identified in the report will all be satisfied by the end of this fiscal year, so by September 30. 3 of the recommendations we've already implemented, and we will provide all of the evidence to OIG after they're completed on September 30th.
So September 30th, that's a hard time. That OIG report is going to be completely resolved.
Yes, sir. And last year, when I testified before your subcommittee, you challenged me to make sure that you were going to hold me accountable, and you can hold me accountable for those dates as well.
Absolutely. Thank you, sir. And I respect your leadership and honesty. Thank you for doing that. My second question is, I ran into a lovely young lady. She was over in Longworth Building, and she had, and for the life of me, I can't remember the exact mechanism that she has a robotic mechanism that allows exoskeleton. Thank you, Mr. Van Orden. And hearing her story of what she had to go through to get that, she ended up having to pay for it on her own, her and her family. And she was telling me the story. And she was a Marine, by the way, so you can only imagine how engaging that story was. My curiosity is, why hasn't the VA stepped up in that space?
Sure. Thank you for that question, Mr. Luttrell. When it comes to exoskeletons, because of the level of independence that's required, there are certain requirements that need to be in place in order to determine which veterans are best suited to actually have an exoskeleton. We have to weigh the benefits and the risks. The benefits are increased mobility and increased autonomy. However, the manufacturers of exoskeletons require the assistance of another person. So even though a veteran may be moving around, in order to get into and out of that equipment, they do require another person to be around. That is stated by our veterans as the largest barrier to them
Sure,
actually.
yeah, her father was with her. But I think I think there may be a communication breakdown because the VA did not come through with her, and she benefits greatly because of her exoskeleton. So I don't know by, with, and through the organization how we need to move the pieces on the chessboard to fix this. I think there's a way to do that, to fix this problem set. I just would ask the VA to take a harder look at the advancements in technology for our members in need.
So thank you for that statement. We are continuing to look at innovative projects and programs to support our veterans. In 2016, I'm not sure when she received her exoskeleton, we did devise a specific type of evaluation for those veterans who are interested in exoskeleton. There are a number of other types of innovative technologies to include neurostimulation and other types of equipment that can help our veterans who have spinal cord injury and disorder. But again, everything is evaluated on a case-by-case basis to make sure that it's the safest for veterans. The downside, unfortunately, of some of these is because of the mobility issues, is that they can have skin breakdown, which can lead to infections and other problems, as well as some other neuromotor issues that can happen with spinal cord injury disorders veterans. So we need to make sure that we're providing care that's not only what they want, but what we think is safe.
Thank you, Doctor. I yield back, sir.
Representative Landon, you're recognized.
Thank you, Mr. Chair, and thank you for the hearing, and thank you all for being here. The GAO report that my colleagues have been talking about, we're talking about here, the number of deficiencies, something like 85% of the facilities had one or more deficiencies. I don't want to get into that. I mean, I appreciate the comment about the report and the fact that the recommendations will be dealt with in some period of time. I have a larger question, which I typically ask around continuous improvement and hospitals in general. We think of them as places where, good things happen and bad things don't. Though we know, and you all know, and the folks here know that bad things happen all the time, and the bad things are really bad in some instances. I mean, these are adverse events or serious safety events, medical errors, these kinds of things. And I bring those up because in Cincinnati, we have a children's hospital, which is now ranked, I believe, #1, but it's 1, 2, 3 every year. And they got that way based on a commitment to being the best at getting better. That's what the board decided. That's what the leadership decided. That's what surgeons and nurses and everyone affiliated with the children's hospital in Cincinnati decided. And it took them years. But they started with the serious safety events, and they wanted to get that to 0 because the only number that was acceptable is 0. They haven't had a serious safety event in over 2 years, and it led them to get very serious about everything, from post surgical infection rates to the customer experience and things like this GAO report and deficiencies and they so for example they had they got a 96% satisfaction rate, and one of the board members one year said that's good, but we see 1 million people every year, so that means 40,000 people were unsatisfied. Let's do better. And it was that, so now they're, you know, they have much higher satisfaction rates. I'm curious about, you know, because you all deal with some of the most significant and complicated medical issues. And I'm curious, what approach do you all have now as it relates to getting better? The measures that you use, what does it look like in terms of the culture? How would you describe where you're at now versus where you'd like to be?
Yeah, so thank you for that question, Mr. Lensman. We are constantly striving to improve the care we provide within our organization. And we also have the same type of stretch goal to have no complications, no falls, no infections, things like that. We have a continuous improvement process that takes place at the medical centers individually. And I do want to make a distinction that the concerns raised in the report were related to the oversight of external organizations that we are sending veterans to, as opposed to our medical centers themselves.
Yeah, and to that, this was just one data point, and it had to do with care unrelated to yours, but the adverse events or medical errors associated with community providers was 2x in one particular area. But we have contracts with those organizations, and presumably they could, you know, ascribe to or be required to ascribe to the same continuous improvement and performance measures as us. So what does that look like?
Right, so one of the things I will talk, and I will let Mr. London add to this answer, is that we're increasing the number of visits that we're conducting to those facilities. You know, this is coming off the tail of the pandemic, where first we didn't travel because it was unsafe, and then there was still a restriction on travel. But Mr. London, would you like to add to that?
Yes, very similarly, we started traveling in April of 2022 to do site visits, and since that time, we've done over 700, including an additional 300 virtual visits, and we plan to continue to do those and increase the number of visits that we're going to have going forward to make sure that we're continuously improving.
I appreciate it. My time's up. Thank you. I yield back.
Mr. Van Orten.
Thank you, Mr. Chairman. Dr. Scavella, we keep hearing the same words and phrases all the time, continuously improving, doing our best, we're shooting this, and, you know, we keep hearing the same stuff over and over and over again. We're trying to get better, we're trying. Will you turn around, please? I'd like you to get the view that, I'm serious, will you please turn around? This is the view that Congressman Luttrell had of these people that are permanently assigned to having to have artificial apparatuses to function and live. So as your department continuously strives to improve and get better and do all this stuff, and the IG report just says you're not, they're still stuck in those chairs, ma'am, while you get to go home. And while your staff that is continuously improving gets to go run in a field with their family, and they don't get to do that. So I am thoroughly unimpressed with your department's performance. And I think that the IG report says that you guys are failing. So when is someone at the Veterans Affairs, when is someone at the VA going to be held accountable to the point where they're not working there anymore?
So thank you for that question. When we do see performance issues, we have to document those and go through a process to separate someone from employment. And when, in those instances, whether it's related to poor care or poor coordination of care, we take those actions.
When is the last time you have fired someone from the VA for poor performance?
I'm not overseeing direct patient care, so my answer to that question wouldn't really be illustrative of what's happening in the field.
Okay. So for what period of time did you not do performance oversight visits during the COVID-19 public health emergency? Was it the entire time?
I will have to turn that over to Mr. London because these were for the Benefits Administration.
Thank you very much for the question. Up until from March of 2020 to April 2022, we were precluded to do in-person travel.
Okay, so what happened during that period of time? The vendors have been doing stuff the whole time, right?
Yes, sir. The vendors were responsible contractually to ensure that each facility that they're used to send our veterans for examinations were safe, sound, and met the requirements of the contract to include OSHA and ADA.
Did you sign an employment contract, sir?
Did I sign an employment contract?
Yes. Like, it says Department of Veterans Affairs.
I'm employed by the Department of Veterans Affairs, yes,
Okay,
sir.
so you signed an employment contract to be held accountable to the people that are sitting behind you essentially in wheelchairs, correct? And yet you failed to do your job during the entire COVID-19 thing, but you expected other people to do theirs, is that right?
Mr. Van Orden, I appreciate your question. I want to make clear that I joined this office in December of 2021. As soon as we were required or allowed to travel, I actually went with the team and did site visits personally to make sure that these sites met requirements. So as soon as I was able,
Who's your predecessor,
under my
sir?
accountability, sir, that's what I'm here to do.
Mr. London, who's your predecessor?
My predecessor is now retired.
Okay, did they retire with full benefits?
I'm unaware of his situation.
Okay, I think you're seeing where I'm going here.
I do, sir.
Consistently, the theme that I get from the Veterans Affairs Administration is that the Veterans Affairs Administration is putting the Veterans Affairs Administration above the veterans. And that's not why you're here. It's not why we're here. So you guys have to understand your bureaucracy is not more important than the people sitting behind you in wheelchairs who are trapped in that reality. And they can't escape that reality. They're clapping for the hope that there will be accountability in the Veterans Affairs Administration, and I join them. And with that, I yield back, Mr. Chairman.
Representative Budzinski.
Thank you, Mr. Chairman, and good afternoon, everyone. I'm glad we're having this important conversation today about the unique issues that are affecting our veterans with spinal cord injuries and disorders, SCID. As my colleagues have spoken to and the OIG report outlined, there is a lot of work to be done for this vulnerable community. I want to focus on an area that I'm particularly interested in seeing improvements, which is with the veterans, the women veterans living with SCID. I've attended several congressional women veterans roundtables with VSOs who are leading in the women's space, including Paralyzed Veterans of America. And I just recently hosted my second Women Veterans Roundtable at home in my district and have heard specific concerns related to today's topic. Women veterans already face very unique barriers when seeking care. And those barriers are only exacerbated among women veterans living with SCID. Many of our health clinics or specialty areas within VA continue to lack basic accessibility measures for those with SCID, and the cooperation among the SCID system and women's health facilities continues to be severely lacking. As you know, one of the main SCID centers in the Midwest is located in the St. Louis VA system, which serves many veterans, including many in the southern part of my district in Illinois. And I want to ensure we're equipping it with the resources needed to provide adequate care for women vets living with SCID. Dr. Scavella, I believe that the VA continues to be the best system for our vets with SCID to get care. But we have to improve what I believe to be communication between systems. So my first question for you is, what steps is the VA going to take to ensure better cooperation and continuum of care between SCID systems and women health clinics in particular?
Yeah, thank you for that question. We continue to partner with our women's health clinics to make sure that they are able to meet the unique needs of the spinal cord injury and disorder community. We are making sure that facilities have the appropriate equipment as well as space to make sure that our veterans who are women coming in for gender-specific care or other care are afforded the privacy, the comfort that they are entitled to. So those are things that are undergoing. The WISE funding has been particularly useful in making sure that we have the ability to provide that care. as well as other pieces of legislation that specifically address mammography and access for women who are spinal cord injury and disorders.
Is there anything specifically that you could speak to, just in observations in what women's health clinics are equipped with today, that would be something immediately helpful to help those women veterans with SCID kind of better integrate into a women's health clinic?
Yeah, thank you for that question. So when we are constructing newer facilities, we are ensuring that doorways are wide enough, that rooms are able to be modified and transitioned so that we can accommodate veterans who may be coming in using motorized wheelchairs, which tend to be larger. And then we can do appropriate gender-specific care in those spaces with our employees who are skilled and trained in those areas. So that's what we're doing with our newer facilities. We do recognize that some of our older facilities have some more challenging navigation, especially for some of the newer motorized wheelchairs that may not be able to get through those spaces.
Okay. I wanted to highlight there have been instances of women with SCID getting a late diagnosis because they had to put off appointments due to these accessibility issues at their nearest women's VA clinics. And this is especially true, as you've just highlighted, for women with SCID who are using wheelchairs. So, Dr. Scavella, how is the VA going to improve access? You talked about the needs, but what are kind of immediate next steps that we can do regarding access to gender-specific care for women living with SCID? And how can we ensure facilities, again, you've pointed out the things that need to happen, but what can we do to take immediate action to make sure that's guaranteed so our women veterans get the care they need?
Yeah, so we'll make sure that we talk to each of our veterans to understand exactly what they need. One thing that we are making sure is happening is for veterans who are coming in with spinal cord injury and disorders, we want to make sure that all routine annual screening is completed, whether we're talking about our women or our men, and that those things are not afterthoughts. So as part of their patient-aligned care teams, they're specialized in spinal cord injury and disorders at those spokes or those centers, those hubs. We're making sure that that is part of the care. And it may look different. We may not bring you physically to a place to get that care. We can provide that care to you either in the facility, in the hospital, or in your home. And then there's telehealth as well as other modalities to make sure that we're doing what we need to do.
Okay, thank you. Lastly, PVA leaders testified at a recent Senate hearing that when providers are made available to SCID clinics to provide OBGYN services, they are often general practitioners that are unable to answer questions specific to women vets living with SCID. Dr. Scavella, again, what can the VA do to better prepare practitioners to provide culturally competent care for women veterans living with SCID that need these services?
So thank you for that question. We do have a number of gynecologists, obstetrician gynecologists, who are employed by VA, and then we do have a number that are in partner with our university affiliates providing that care. So those are two of the ways we can make sure they're receiving the highly skilled gender-specific care that they require. And then if we do have an internist or another specialty that has the skills and the training to provide gender-specific care, we just make sure that they are educated on this particular population. We have ongoing engagement with the Spinal Cord Injuries and Disorders National Program Office to provide training specific to our veterans, as well as other types of engagements, face-to-face, virtual, on an ongoing basis, as well as a community of practice. So we're really making sure that we are giving our employees the skills that they need, as well as bringing in the skilled providers, physicians, to provide that care.
Thank you very much. I yield back my time.
Thank you, and thank you, Dr. Scavilla and Mr. London and Mr. Brici, for testifying today. You're excused, and we would like the second panel of witnesses to approach the witness table and get ready. Thank you. Testing. I would like to welcome Mr. Robert Thomas, the National President and Chairman of the Board of the Paralyzed Veterans of America. And accompanying him is Mr. Carl Blake, the Executive Officer for Paralyzed Veterans of America. Mr. Thomas, if you would, I would recognize you for 5 minutes to give your PVA's testimony.
Thank you. Chairman Boss, Ranking Member Takano, and members of the committee. I appreciate the opportunity to testify on behalf of the tens of thousands of veterans with spinal cord injuries and disorders who rely on the benefits and health care available through the Department of Veteran Affairs. For nearly 35 years, I have navigated the VA health care and benefits system following the spinal cord injury I sustained while on active duty. The care and benefits available through the VA not only saved my life, but have given me the ability to have a family, work, and serve my fellow veterans. Most recently, as you stated, as Paralyzed Veterans of America National President and Chairman of the Board. I received my medical care through VA's direct care system. However, about 10 years ago, I was in a motor vehicle accident. I was taken to the nearest community hospital for immediate care. I recall the emergency room doctor asking me if I was in pain from the accident. I told the doctor that I was paralyzed and unable to feel such pain. Without further examination, I was given pain medication and just released. I knew that I needed to get to the VA, where I later received the proper examination. I know firsthand why people with spinal cord injuries who didn't serve tell me that they wish they could access the care and support available through the VA. Without the VA's SCID system of care, I do not know where I would have been. And many of the men and women sitting here behind me would say exactly the same thing if they're speaking today. That's why we become so concerned when the SCID centers have to close beds because they don't have enough nurses to properly staff them. Veterans Health Administrative Directive 1176 provides the staffing guidelines to allow healthcare professionals to properly care for veterans with SCID. Depending on the function level of an acute SCI patient, a nurse may spend an hour or more each time with the veteran's room. That's why it is important for SCI centers to have higher staffing levels than other wards. We need every level of VHA, including central office, divisions, and the individual medical facilities to take seriously the requirements of VHA's Directive 1176. We need the VA to properly deploy its resources and request the funding needed to provide the level of care outlined in the directive. If the VA system of care isn't properly funded to ensure the staffing levels meet the needs of the veterans with SCID, then our government is defaulting on a promise made to care for us who become catastrophically injured or ill in our service to this great nation. It's not just acute post-injury or diagnosis that we depend on. It's also the lifelong care that allows us to remain independent. Caregivers are tremendously important for veterans with catastrophic disabilities. My wife, LaShawn, is not only my spouse, she's also my caregiver. I mentioned Andrew, a veteran with ALS, when I testified in March. It's only because of the tremendous advocacy of Andrew's wife, Lisa, that he is still receiving care at home. Recently, she took the exceptional steps of petitioning directly to the Undersecretary of Health, which compelled his local facility to recalculate the cost of his care. in an attempt to delay his reaching the statutory cap. No family should be forced to take such aggressive measures. The Elizabeth Dole Home Care Act would fix this problem. We need Congress to pass the Senator Elizabeth Dole's 21st Century Veterans Health Care and Benefits Improvement Act, which includes this important legislation. I and my fellow paralyzed veterans believe that the backing of every major veterans organization should be enough to get H.R. 8371 through Congress without further delay. Andrew can't wait anymore. Lisa can't wait anymore. We can't wait anymore for Congress to do the right thing and pass this bill. I'm grateful for the support I received through the VA, but my fellow veterans and I are concerned about the future of the VA SCID system of care. Without a robust system, we are in danger of living diminished, shortened lives. This is not what we fought for, and it is not what we will settle for. Thank you for the opportunity to provide you with my perspective on VA's SCID system of care, and I'll be happy to answer any questions.
Thank you, Mr. Thomas. Mr. Blake? Mr. Blake, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I've been here a long time, and you mentioned earlier how long you've been here and don't recall a hearing on SCID. I've been here a lot longer than you have, and I can't recall an oversight hearing on this, so I certainly thank the committee for its willingness to address this issue today. I sat there last night, and I was trying to think, what could I tell you that would get your attention, that would get people to listen and understand what Robert was just saying? I've never told my story, ever. It's just a personal thing I don't do because it's personal, but I'm going to share a little bit of my story. I am a PVA member. I have a combat-related spinal cord injury. I was told by the Army once, if I don't die, I will never walk again. I was told by a private medical facility, there's no chance this person will ever walk again. I rolled into the VA SCI Center in Richmond, Virginia on a gurney, and I walked out of there after 12 months of rehab. The VA did that. So while the VA gets a bad rap and gets beat up, it is a valuable system to our members. I do want to say, I appreciate Dr. Scavello's testimony. Clearly, she spent a lifetime committed to veterans and the VA, and she's to be commended for that. But I think it's important that we step back now and realize what's really going on in the SCI system of care. The fact is, the SCI system is at a breaking point. We survey all of the SCI centers on an annual basis. Every month we do bedding staffing survey of the SCI system of care. This is what we know to be true. There are staffing shortages all over the system. It's not 9%. It's more like 30%. There is a severe lack of resources dedicated to this system of care. The VA has a larger financial problem that, for whatever reason, no one is willing to admit and accept. The VA has been given a lot of money over the years. We recognize that fact, especially in recent years. But what the hell they have done with it, we don't know, because where it has been directed is not towards the SCI system of care. We met with the SCI leadership from all over the country a couple of months ago, and here's what they told us. They can't hire anyone, not just because there aren't providers available. There are no incentives to bring people on. There are people who are interested in working in the system, and those are the most dedicated people. The system is not set up to bring those people on board in an efficient manner, and most of the time they're lost. The HR process is broken. It does not serve the needs of the system to bring people in an expeditious manner. We've heard a lot about net zero growth in VA because of the fiscal challenges it has. It's not net zero, it's net negative. This is what's happening in the SCI system of care. When a position comes open, it's not only not being filled, in some cases it's being abolished, taken off the books. The VA's handbook 1176 expressly says this is what the staffing methodology and model should be for VA, and these are the policies and processes that should be followed for providing direct care. And those leaders across the system told us that they have been told at the local level and even up to the VISN level, we don't care what 1176 says. We are not beholden to that. It is not the law. That's bullshit. If you're going to craft a policy and a process to deliver care, then you should follow. And if you're unwilling to do so, admit why. As it is, our members are struggling to get the care that they need, and the system is at a breaking point. We don't want to ask Congress for more money. We recognize the challenges that is faced across the entire spectrum. But resources are going to have to be put in the system somehow to ensure that they are able to staff, provide the equipment, and build the capacity that they need. There are centers that are actively being degraded today. They are actively closing beds today. The system is shrinking, but the population that needs this service is not. Yes, it's getting older. That doesn't mean the population is shrinking. Some real effort needs to be put into rejuvenating this system, or it's going to collapse on itself. And everyone in this room and everyone listening and all of our members are going to suffer because of it. There were questions about women's health care. They will be irrelevant if we don't fix this system before it is too late. But that is close to where we are now. It's important that we all understand the VA has a vital role to our members, to all veterans. If veterans want to go out into the community, PVA doesn't have an express opposition to veterans getting care in the community. It's a necessary tool for the VA. But that option is not available to our members. It is only the SCI system of care that makes their care possible. And we have to invest in it. If we do not, there are much worse horror stories that could come from it. We're here pleading with you to actually put the emphasis behind it. All the memos in the world, all the policy directives in the world don't do any good if it's not being enforced. It's all well and good to say, we support the system of care. Well, show it to us, because we don't feel like that's what's happening today. Thank you, Mr. Chairman.
Thank you, Mr. Blake. I now recognize Ms. Sonia Sotak, the Chief Government Affairs Officer of IMALS, for 5 minutes to deliver your testimony.
Good afternoon, Chairman Boss, Ranking Member Takano, and members of the committee. It is my honor to be invited to testify today on behalf of IMALS and the ALS community, including the approximately 6,000 veterans living with ALS in the United States. ALS, commonly known as Lou Gehrig's disease, is a 100% fatal neurodegenerative condition. Upon diagnosis, individuals are told, get your affairs in order, go home, and prepare to die, with the current survival rate being 2 to 5 years. ALS strips away a person's independence, gradually robbing them of the ability to walk, speak, and eventually the inability to breathe. Tragically, every veteran diagnosed with ALS will succumb to this disease, regardless of how hard they fight or how hard their valor is. Every veteran will lose their battle against ALS. As this committee is aware, ALS in veterans has been determined to be 100% service-connected, with veterans being twice as likely as civilians to develop the disease, and post 9/11 Air Force veterans showing a 10-fold increase in incidence. It is estimated that 5,000 to 6,000 of the 30,000 individuals living with ALS in the United States are veterans, roughly 16% of cases. However, these figures are approximate due to challenges in accurately diagnosing ALS. After being diagnosed, many of our veterans and their families must take significant time to advocate for themselves while managing the disease. And frequently, it is to explain to the VA what their VA benefits are as a veteran with ALS. To help veterans navigate this complex system, IMALS's veterans team developed a comprehensive toolkit that outlines the available benefits for veterans, including how to access them. While our community of veterans with ALS are incredibly grateful for the VA benefits available to them, this toolkit underscores the complex nature of the benefit structure, which often leads to veterans and their families diverting valuable time and energy to navigate and advocating instead of being able to focus on their health. Lack of knowledge of the VA system can result in frustration and delays in service. Because ALS can progress rapidly, delays need to be avoided at all costs. Congress recognized this when you all worked together in a bipartisan manner and passed the ALS waiver eliminating the SSDI waiting period in 2020. Our veterans with ALS and their families deserve the same recognition when accessing benefits, including home health care. While the VA Spinal Cord Injuries and Disorder Centers are equipped to address the needs of veterans with static spinal cord injuries, they often struggle to meet the complex requirements of ALS care. ALS demands a multidisciplinary approach and specialized equipment that many SCID centers lack. Geographical barriers of the centers compound the challenges faced by veterans with ALS, especially those not living in certain urban areas. Based on the needs of our ALS veteran community, IMALS is asking for an increase in this expenditure cap for non-institutional care from 65% to 100% of the cost of the closest VA community living center through the Elizabeth Dole Home Care Act, which is included in the Senator Elizabeth Dole 21st Century Veterans Healthcare and Benefits Improvement Act. By raising the cap to 100%, veterans with ALS and their caregivers will be able to access healthcare in the comfort of their homes. This will enhance the quality of life for veterans with ALS and alleviate the burden on their families and caregivers. IMALS and our veteran community also appreciate that the Elizabeth Dole Home Care Act acknowledges the crucial role of caregivers, often family, in managing the daily needs of veterans with ALS. The Act offers resources, training, and financial assistance to caregivers, easing their emotional and financial burdens and enabling them to provide improved care and support to our veterans. I'm going to take a moment to share with you the impact of this legislation could have had on our Navy veteran, Garrett. Garrett served as part of the Seabees, a Navy construction battalion with tours in Iraq and Afghanistan. Garrett's battle with ALS epitomizes the challenges many veterans face, especially when trying to remain in their homes as the disease progresses. When Garrett was first diagnosed, he and his wife attempted to manage his care at home, with most of his care falling on his spouse to avoid reaching the 65% cap. However, despite their efforts to navigate the system, Garrett was trapped in a cycle of bureaucratic red tape. Garrett eventually required more assistance, surpassed the home cap, and was put in an institution. Garrett elected to remove his trach, ending his life early rather than being isolated in an institution. Garrett simply wanted to be at home. At the end of his life, Garrett felt hopeless and out of options. His heartbreaking decision to end his life because of the complex system not providing the best support for his final battle shows the urgency of passing this legislation, and Garrett is not an outlier. Unfortunately, I can tell you about other veterans who have had the same circumstance. Through the Elizabeth Dole Home Care Act, you can improve the quality of life for veterans living with ALS and their caregivers, as it provides them with flexibility in how they receive care. I'll end. I know I hit my time. I don't want to go over.
Thank you, Ms. Ote. Now we recognize Dr. Jenny Karatley, representing the American Federation of Government Employees. Dr. Karatley is also the Director of Spinal Cord Injury Clinical Research for the VA Palo Alto Healthcare System. Doctor, you are recognized for 5 minutes to deliver your testimony.
Chairman Bost and Ranking Member Takano and members of the House Committee on Veterans Affairs, thank you for inviting the American Federation of Government Employees, AFGE, to participate in today's committee hearing on meeting the needs of spinal cord injury and disorders veteran community. You've just introduced me, so I'll skip that. I'm a member of the AFGE since 2009. AFGE's National Veterans Affairs Council represents more than 302,000 AFGE VA employees. My role at VA as a research health scientist in the SCID Center at VA Palo Alto since 1991, with more than 30 years of experience conducting research on clinical issues affecting people with spinal cord injury. In addition, I'm on the faculty of the SCI Medicine Clinical Fellowship Program and a member of our SCID Center Leadership Council. As you have been hearing, I'll reiterate, the VA Palo Alto SCID Center is one of the 25 VA SCID centers that offer lifelong, comprehensive, integrated, coordinated care, including primary care, rehab, emergency care, acute medical and surgical care, mental health care, and home care, aimed at supporting the veteran as a whole person with services that reintegrate veterans in the community. Care is also delivered via telehealth, which VA Palo Alto pioneered in 2000 and has expanded tremendously to enhance access to VA services remotely. SCID providers include physicians, nurses, psychologists, social workers, physical therapists, occupational therapists, recreation therapists, who coordinate care with many disciplines such as pharmacy, radiology, urology, orthopedics, plastic surgery, and many other clinical services. The expertise of the interdisciplinary care team and breadth of services available makes the VA SCID network based on a hub and spokes model, the most comprehensive healthcare system for people living with SCID in the U.S. Primary care physicians need special training to serve the specific needs of this patient population, as they must be able to diagnose and treat an array of problems that may present differently, such as bone fractures and infections. They also must be trained to recommend appropriate preventive care screenings and manage comorbidities, such as metabolic and musculoskeletal disorders, in collaboration with other specialists. Most physicians in the VA SCID centers pursue an additional year of specialty training through SCI medicine fellowship programs, and VA plays an important role in these training programs in collaboration with academic affiliates. However, more needs to be done to encourage young clinicians to enter the field of SCI medicine. Of the approximately 31, 32 positions in SCI clinical fellowships, usually fewer than 20 positions are filled in any given year. Another unique aspect of the VA system is the large and very active research enterprise, which I'm part of. Clinical research conducted at the VA Palo Alto, SCID Center, and other VA centers can drive improvements in care delivery that also may benefit non-veterans living with spinal cord injury and disorders and contribute to best practices. One of my current projects is a collaboration with the Minneapolis VA to evaluate a novel wheelchair that provides mobility while standing. This adaptation will allow greater time in an upright position and thus reduce the risk for pressure injuries, improve blood flow and bladder and bowel function, reduce spasticity and pain, as well as enhance functional capabilities of the user. VA Palo Alto also was involved in the multi-site VA research to explore the effect on quality of life with exoskeleton-assisted ambulation, as well as a project a few years ago to implement and evaluate a model of vocational rehab to return individuals with SCID to employment. Other recent projects that I've been involved with include exploration of video gaming as a mode to elicit upper extremity muscle activation, and a current study to improve evaluation of fracture risk by determining a reliable method to measure bone loss at the knee, a common fracture site. Through its research and clinical care initiatives, VA is at the forefront of improving clinical outcomes and quality of life for veterans and all people living with spinal cord injuries and disorders. However, more can be done to strengthen the VA SCID system. There's a great need, as we've been hearing, for increased staffing for SCID services. Staffing requirements for SCID centers should reflect the high acuity and complexity of care needed, which often requires specialized certification and advanced training. The high acuity of care creates burnout, and younger clinical staff often leave just as they've gained sufficient skills to perform all their duties. Additional retention incentives are needed to address vacancies and turnover, with specialty pay as a high priority. In summary, the VA's SCID model provides uniquely comprehensive and integrated services delivered by highly knowledgeable teams of specialists that do not exist in the private sector. While the Mission Act increased access to non-VA facilities, use of VA and non-VA care has the potential to increase unintended duplication of services, costs, and fragmentation of care. And the risk of inadequate care is a great concern for veterans with SCID because of the need for specialized expertise. In addition, non-VA providers lack access to VA resources such as medical equipment and a wide array of adaptive products, often created for each individual for his or her specific needs. Care should be taken to ensure that increasing privatization of VA services does not upend the VA's specialized SCI care model that provides an array of integrated services and supports research used to develop best practices for all people living with spinal cord injuries and disorders. And thank you very much for this opportunity.
Doctor, thank you for your testimony. We're going to now go to questions, and I recognize myself for 5 minutes. Mr. Blake, in PVA's opinion, why is it necessary for Congress to pass H.R. 8371, the Senator Elizabeth Dole 21st Century Veterans Health Care and Benefits Improvement Act to continue improving services for your membership?
Thank you, Mr. Chairman, for the question. So a lot of our members rely on home care services, home-based services. The Veteran-Directed Care Program is a very popular program for our members where it's available. The Elizabeth Dole Act would make those opportunities much more available. It would eliminate the 65% cap. It would allow our members to be at home where they want to be and receive the care that they need and not end up in simply a facility, and would just improve their independence and opportunities. So I think if the bill doesn't get passed, then our members will continue to struggle along, or we're going to end up in a situation like the lady from IMALS mentioned. Those are totally unacceptable circumstances. That should never happen simply because of some arbitrary cap or some limitation on home care services that are available.
Thank you. Ms. Sostak, can you explain why VA must ensure that accessibility and safe contracted exam facilities are available right away for veterans with ALS?
Sure. Thank you for the question. ALS progresses quickly, not for everybody, but for many. And some veterans have limited mobility at the time of their diagnosis. And so for that, we believe that contracted exam facilities must be accessible. And I think we heard earlier testimony saying that is sometimes and very often a challenge. And we need to make sure that they get in quickly before their disease progresses more, and we're able to hopefully mitigate the rapid progression of that disease.
Thank you. Mr. Blake, VA told the committee staff that they were operating at about a 9% vacancy rate for the clinic staff. I think in your testimony you said that you probably don't believe that. What do you believe it actually is?
Well, let me correct it. I don't believe that that's not true. We simply think it's not true. We survey the system of care every month for its bed and staffing, and according to our own medical services records and our team that surveys that system, we believe that vacancy rate is closer to 30%, not 9%.
Do you think that the VA has the staff needed to safely care for the groups, for this group of veterans?
Well, I could just simply say no, that would be too easy, but the answer is no.
Yeah.
Clearly it's not, because the system is actually being drawn down. It's not being expanded at all.
Mr. Thomas, can you tell me why it is important to have competent, properly trained clinical staff when you're being treated at SCID veterans?
Thank you for that question, Mr. Chairman. So I can simply say that, our lives, my life, the life of our members are in their hand. So we really need them to be able to diagnose us when we come in, because only thing that we know is something's going on. We can't tell exactly what it is, but we need to rely on these doctors and nurses to tell us what is going on, and not just simply provide us with some medication and say, I'll see you next time. Check back with me in a week.
I think you said in your opening statement that, we know VA wants to provide this. We've just got to make sure that we do the oversight to make sure that it is doing it at the top level that you all deserve. We want to continue to work to do that. And with that, I'm going to turn over to Mr. Takano for his questions. Recognized for 5 minutes.
Thank you, Mr. Chairman. I want to start with Dr. Karatley. Dr. Karatley, can you expand on the training and continuing professional education that clinicians have to undergo to be able to provide appropriate care to SCID veterans? And we have been talking about the importance of highly trained people to take care of this SCID population. So can you expand on the training that's necessary?
Thank you for that question. Yes, I'm glad to. We have one of the clinical fellowship training programs at our facility in Palo Alto, and it is a year-long intensive program for physicians who want to have a subspecialty in spinal cord injury medicine. They become board certified. It includes exposure to inpatient, outpatient, all sorts of additional specialty trainings that can be provided. We partner with, our program at Palo Alto is actually under Stanford University, and we partner with the community SCID center nearby. Most of the programs, many of the programs involve VA, but not all. And when residents choose programs, often they value being able to be at a VA to gain that training, the training opportunities to work with veterans in the system for the high level of specialty training that they can get.
Well, thank you. Does VA cover all the costs of the ongoing training?
No, not that I know of.
They don't. They don't cover the ongoing costs of the continuing education they need to do.
No, the various professionals have requirements for ongoing training. For instance, physicians have to re-certify board training. We have a variety of other specialty certifications, such as wound training, high-level seating training. I think there's some funds available, but it certainly doesn't cover all of it. There's a limited amount available for conference attendance.
It's fair to say that it takes thoughtful investment in VA's workforce in order to provide the high level of care that SCID veterans require and deserve. Would you say that's right?
Absolutely, and well said.
So my colleague Julia Brownlee has an important bill, the VA CPE Modernization Act, H.R. 543. We've been stymied in advancing this bill because of its costs, estimated by the CBO to be about $3.3 billion in combined discretionary and mandatory spending over the 10 years. This is addressing the cost of training SCID employees. However, I think this would be a very worthwhile investment. This legislation would provide stipends of up to $2,000 per year for VA clinicians continuing professional education expenses. And what would this mean for employees if for VA's SCID system of care? It would mean a lot, would it not?
That would be wonderful.
Well, I would like to change to Mr. Thomas. Mr. Thomas, in your testimony, you highlighted how VA's SCID system of care is uniquely positioned to meet VA's PVA members, your members. Why do you think it's so important to ensure that VA is able to continue to meet the needs of SCID veterans?
Thank you for that question. So I believe that being able to meet the needs of all of my members, myself to be included, is that it's very important because, outside in the community, as I stated in my oral statement, that, the doctors don't know. They're unsure of what goes on. So the specialized training that's provided for VA clinicians and everything, it's important to us to make sure, again, we can be diagnosed correctly, they know what's going on. Prime example is if an individual comes up with autonomic dysreflexia and the individual doctor doesn't know how to treat that, it can become very severe to our members and to myself as well. So, having those specialized care, having a specialized care system available to us means a lot.
So our current investments in VA infrastructure and direct care, not community care, direct care for veterans with SCID, are they sufficient?
I would turn that over to our CEO, Blake, to answer that question.
I'll answer it like the other question, no.
Thank you. Well, I agree with both of you. Congress needs to make more considered effort to balance the amount of funding going out of VA to private sector providers rather than into VA in the form of investments in the direct care workforce and improvements in medical care facilities. Would you agree with what I just said?
Yes.
Yes.
Well, I'm glad we agree on that premise. That is why we must continue to prioritize efforts that invest in VA. And I believe investments in VA are investments in veterans, especially veterans who truly depend on the specialized care that VA can offer. We need to build on that offering and expand it as well as other benefits. In your testimony, you mentioned the importance of enacting legislation like the Autonomy for All Disabled Veterans Act, which would increase grants for veterans to make structural improvements to their homes, and the Rural Veterans Transportation to Care Act, which would provide innovative transportation options for veterans traveling to medical appointments. I agree that these should be priorities for Congress and that we should ensure that we advance these kind of bills. Now, I'd like to go back for a moment to Dr. Karatley. What kind of feedback do you hear from physician fellows and other providers about training they've received at VA? What do they like about practicing at VA versus in the private sector?
Thank you for that question. It's an excellent question. The constant feedback we get is how the clinicians are able to practice medicine that they've been taught. They have access to the specialty services, they have access to resources, and they don't have to curtail or prioritize care based on what might be available to support it. So it really allows them to practice to the fullest extent and in the best interests in the health and well-being of the patient.
Well, thank you. I yield back. Sorry, I went over my time.
Not a problem. General Berkman, you're recognized for 5 minutes.
Thank you, Chairman Bost, for holding this hearing and giving us the opportunity to focus on the needs of our paralyzed veterans. As has been made clear through the testimony today, there are a wide range of reforms and improvements needed at VA to ensure the best possible care for these veterans, and I appreciate being able to hear our witnesses' support for bills like the Elizabeth Dole Home Care Act. My focus today will be on VA's annual health assessments for spinal cord injured and disabled, or SCID veterans, as well as access to assistive devices to promote mobility and independence. As a note, when you were talking, Doctor, you talked about inactive versus active care, and I would suggest to you that things like an assistive wheelchair to stand and all that is outstanding. It enables that patient, but I also believe that on the active side, things like the exoskeleton probably promotes more active care, but I'll leave it to the scientists to decide that. Mr. Thomas, great to see you again, as always. Last time I think we talked was over on the Senate side. Could you please describe the benefit of these annual preventative health assessments for SCID veterans?
The benefit to having an annual exam would be that you could stay ahead of any issue that may be coming up. And the doctors are aware of the smallest thing that the individual hasn't came to that realization that is going on and happening with them. For me, I didn't know that I was coming down with type 2 diabetes without going to this annual exam. So doing that, it get me to be on top of that and find a way to try and not be too diabetic, if I could say that, or if that's a real way. But it prevents everything. So to me, medicine is preventive care anyway.
So basically, what I'm interpreting you to say that VA should, wherever possible, be doing more to ensure more paralyzed veterans nationwide are made aware of, and then therefore are able to receive these assessments. I assume a simple yes would probably be.
You're absolutely correct.
Right,
yes.
Roger that, okay. And regarding assistive devices, do you feel there are improvements that can be made to ensure paralyzed veterans are able to be assessed for and provided with devices that they are clinically eligible to receive based upon the assessment of the individual veteran?
I would also say yes to that. And if there's any new and innovative technology that comes out, I feel that they should always be on top of that so that they can increase our mobility access.
Perfect. You know, as veterans, we know what we've been subject to some interesting new technologies over the course of our careers, and let's keep it to the good ones and advance capabilities and a better life for others. While the VA has procedures in place on paper to provide annual assessments for SCID veterans and provide them with assistive devices, the reality for many paralyzed veterans has shown that there is more that needs to be done. I'm grateful for PVA's support of my bill, H.R. 6373, the Veterans Spinal Trauma Access to New Devices, or Veterans Stand Act, which I introduced along with Chairman Bost, Health Subcommittee Ranking Member Brownlee, and Congresswoman Debbie Dingell. This bill will codify the VA's obligation to offer annual examinations for SCID veterans, take steps to improve outreach for those who are eligible, and ensure paralyzed veterans are able to be assessed for and provided with assistive devices. As I said, there's still a lot of work to be done on behalf of our paralyzed veterans. I hope this committee will advance the Veterans Stand Act so we can make the progress necessary in those efforts. And with that, I yield back.
Thank you, General. Ranking Member, you're recognized for closing remarks.
Thank you, Mr. Chairman. Chairman Bost raised concerns at our budget hearing in April about significant year-to-year increases in VA's overall budget. I would love to work with the chairman to address this unsustainable trajectory, as it's pretty clear that community care is placing the biggest strain on VA's budget. The chairman and I seem to have fundamental philosophical differences about whether community care should be funded at the expense of other veterans' policy priorities. H.R. 8371, the Veterans Package, would throw another $1 billion at community care in the short term, and at least $3 billion if we extend temporary authorities beyond the sunset dates included in the bill. I'm sorry, I just cannot in good conscience throw more good money after bad and further expand community care eligibility. Especially not when VA is already proposing to transfer as much as $10 billion from direct care and VA facility infrastructure to community care in fiscal year 2025. PVA members are among the most medically vulnerable veterans VA serves, and they will suffer the most if Congress does not properly fund the VA direct care system by investing in VA's workforce and medical facility infrastructure. Now, it's up to the chairman to put the bill on the floor that can pass. And I've been very clear about my concerns. We are in agreement on about 95% of the provisions in H.R. 8371, including those taken from H.R. 542, the original Elizabeth Dole Home Care Act, which passed the House more than 6 months ago. However, if we want to act quickly, the Senate should pass Congresswoman Brownlee's bill right now. Then we can actually spend time on the provisions that need more work and that have received very little progress, including getting updated stakeholder input and more information on the true cost of provisions that are going to have lasting impacts on VA's ability to deliver care. Thank you, Mr. Chairman, and I yield back.
Thank you, Mr. Takano. I would like to thank the witnesses for coming today. I would like to thank the veterans and the veterans' families that are in the audience for your service and everything that you've provided for the great country that we live in. We would not be able to do our work in this committee without each and every one of you. I want to say again that many of the issues raised today will be addressed with the passage of H.R. 8371, the Dole Act. I ask unanimous consent that all members shall have 5 legislative days in which to revise and extend their remarks and include any extraneous material. Hearing no objections, so ordered. The hearing is now adjourned.